We are. Good morning, good afternoon, good evening, wherever you are. Thank you very much for joining us today. We are going to do our PBC Foundation live Q&A. And welcome. Thank you very much. Okay, we are saying welcome to Dr. Martin Weltman from Sydney, Australia. And we're welcoming you as well. But bear in mind that what we're trying to do today is not to give you specific medical advice, but we're going to give you some general medical information. And we hope that this does not replace or substitute for your consultation, but hopefully it empowers the conversation you have in your next clinical appointment, and it gives you the answers that you need. And on that note, I will say hello, Martin, welcome. How are you? Wonderful. Okay, right. We have lots of questions today. For any questions in the room, please do bring them to us, and we will go through the best that we can. Okay, first question for you. So somebody's been diagnosed. They've started URSO. They had a FibroScan. There was no liver damage. Kilopascals 5.7. There's a CAP score of 254. So I'm first going to ask you, what does that mean?
Sorry, can you repeat that? Sorry, Robert.
So they have their FibroScan says it's 5.7 kilopascals and a CAP score of 254. So before we get to the question, what can you tell me about FibroScan, kilopascals, and the CAP score, please?
Okay. So the FibroScan's main use is to liver stiffness, which is the 5.2 or 5.4, whatever that exact number was, which is a normal number. It indicates there's no fibrosis. FibroScan, by the way, has never been validated. It's only been validated for hepatitis C and B, although we use it in all forms of liver disease. So we put a caveat on that because it's never been properly, there's no studies validating it in less common diseases. The truth is, and our experience is that it probably applies equally as well. So FibroScan uses sound waves similar to an ultrasound, but it measures elasticity or stiffness of the liver. And from there, you can infer fibrosis depending on the score. And a normal score is probably less than 6.5.
Okay.
And depending on how high it is, there are varying levels of fibrosis or cirrhosis. A CAP score, CAP score, which I think is what that person's referring to, they use that ultrasound, because it is an ultrasound as well, to try and estimate the level of fat in the liver, and it's mainly used in people with fatty liver disease. So you can try get an estimation of quantity. It's a less accurate tool because there's not great validation studies, but in saying that, because it's not invasive, it's quite widely used. And over time, if they're repeat tests, it does have use, because you can usually say that fits in with a clinical picture, so it's likely to be very accurate. And that's the simple explanation. There are more complicated explanations, but that's the simple way that I would understand it.
Okay, perfect. That's helpful. Thank you. So now that we've got a better understanding of FibroScan, my question that's put to us, and I'm going to put to you now, could I ask, however, if there had been fibrosis, is that something that may be reversed or improved upon by weight loss and healthy eating?
So we don't think, traditionally speaking, we think when you get scar tissue or fibrosis, it can't be reversed. It probably depends on the type of liver disease, to be honest. And a lot of drug interventions where they give a drug and they do a liver biopsy before the drug, and then they do a liver biopsy a year or 2 or 3 down the road after the drug, have shown reversibility of fibrosis. So the way we understand it, if you at least have mild to moderate fibrosis, you can probably reduce the severity of that fibrosis over a longer period of time, not in a short period of time, but over a long period of time. So that intervention may be, if you've got a lot of fatty liver as the main cause, if you looked after yourself and looked after your risk factors and ate healthily and exercised and lost weight, you would probably find that the fibrosis score declines to a degree, yes. Okay. And the CAP score would definitely decline.
That's ideal. So I don't know if I'm allowed to share this or not, but I'm going to go for it anyway. So we have data from our patient conference. We had 2 years of data where the patients attending the conference were able to access FibroScan results. And every single patient that had an abnormal liver fibrosis score, particularly the CAP score, who were given lifestyle advice, when they came back the year after, their kilopascal score improved and their CAP score improved. So, and we've popped that into a poster, which we've submitted to EASL. So fingers crossed we'll be able to share that with you more formally. But, so don't tell anyone, because it's under embargo. But we will find out. Anyway, moving on. Martin, hello from Tabuzentak, which is in New Brunswick, Canada. Question is, if you start on 13 milligrams per kilogram of URSO and your ALP remains elevated after 1 year, does it help to readjust the dosage to, for example, 15 milligrams, or would you look at a second-line therapy?
It depends on how high the ALP is. If it's still substantially elevated, I would say, look, I'd say in general, almost certainly not, that you should at least start considering a second-line therapy if you have that available to you. I would definitely at least have that discussion and consideration, yes.
All right, perfect. Thank you. If you've started OCA 5 milligrams daily, OCA being a beta-cholic acid, and your numbers come down to normal, what, if any, benefit is there to increase your dosage to 10 milligrams daily?
So I'm going to answer this in two ways. The dose of 10 milligrams is what the studies show and what the drug is registered for as the optimal dose in terms of both short-term and certainly long-term liver benefit and disease benefit. So you could look at it that way. On the other hand, if you normalize your liver tests, and particularly your ALP, you could probably stay at 5 milligrams. We don't know, but no one's done studies to know if that's the best thing. If I had a patient in that scenario and they wanted to stay on 5 milligrams, to be honest, I'd probably keep them on 5 milligrams because it probably is. No one's just done the study to look at that.
Yeah. Now, Martin Weltman, you're not telling me that you now are going to open up the discussion about real-world evidence and using medicines in the real clinic? Let's not go there. Let's not do it. Let's not. Right, okay.
I've shaken enough leaves with that, as you know, Robert. I'm not sure.
So, okay, right. Oh, now, right. Here's a question. I'm trying really hard not to respond to this myself. I have been told my PBC is quote unquote latent. As my ALP, my liver tests have returned to normal. I'm no longer on URSO because of this. Does this mean I'm in some kind of remission? I thought I was supposed to be on URSO for life. Martin.
So I'm not going to speak to what your specific situation. I'm going to, because I can't, I don't look after you, and I'm not sure what the doctors have done or seen. If you needed to be on URSO for a high ALP in the context of PBC, you need to be on it long term. Latent, I don't like the term latent disease, except in a situation that's very specific. We sometimes get people who have an antibody that we use to diagnose PBC, the antimitochondrial or AMA antibody, positive. They send the patients to us because the test is positive, but the liver test, and in particular the ALP, is entirely normal. Those people don't really need to be on treatment. They need to be watched because they may evolve into blown PBC and a higher ALK phos, and then you would introduce treatment. But some of them may never evolve into full-blown disease, so may never need treatment. Their liver tests need to be watched and an eye kept on them, probably on an annual basis at least. If someone had abnormal liver tests and they've come back to normal, that's the goal of treatment. But those people will relapse and don't have latent disease, and those are the two contexts, and then they should never come off, in my opinion, should never come off URSO.
Okay, perfect. Thank you. I'm glad you said that, and that's again reassured supported by the recommendations in almost every major PBC
And
care.
every guideline, every major journal article, and every major expert would say that. I don't think anyone would say otherwise.
Okay, perfect. Thank you. We have a question here now. It's to do with the UK, but I'm going to ask you in terms of what is your experience in Australia.
Sure.
So, at what stage in a PBC journey should you be considered or talk to your consultant about a third line therapy? So, be a kilopascal score on FibroScan or ALP or bilirubin levels, what factors or any factors should be taken into consideration if you're considering a third line treatment?
The third line therapy is a relatively new concept, if I'm going to be honest, because we've barely got second line therapies in a lot of countries, and some countries still don't have the benefit of second line therapies. So if someone's not, ALP is not responding and certainly heading downwards way below the 1.67 times normal and heading towards normal, ideally normal, because that should be our ideal goal, then we should think of whatever options we have. In Australia, we don't have the luxury of having third line treatment. So the payer, which is our health system, our government health system, we have to choose a second line therapy and stick with that second line therapy. So the way around it, we couldn't give a PPAR agonist, which is a popular second line therapy, and obeticholic acid. We have to choose between them. But we could give an old-fashioned PPAR agonist like fenofibrate or bezafibrate if we had that available. We have fenofibrate available in Australia. And then add obeticholic acid to that. You can't give fenofibrate plus one of the newer PPAR agonists like elafibranor or seladelpar. So they can't be combined. So there are challenges, and there are challenges about availability, and that goes towards financial availability and the availability of the drugs. But I certainly would like to consider third line therapy if someone's ALP isn't responding to second line therapy.
Okay, perfect. So let me recap what I think I heard. So expense of the new drugs is an issue, and the new drugs are obeticholic acid, elafibranor, and seladelpar. So it's unlikely that a patient would be on obeticholic acid and one of the ELA or SELA.
Correct. They're not allowed to do that. Certainly in our situation, there'll be no payment available for that.
Okay, perfect. And there's no point going on ELA or SELA plus one of the fibrates because those mechanisms are
that'll be they're similar mechanisms, and also you potentiate the risk factors and side effect profile. So that might be a dangerous practice potentially.
With you. And so if you're looking at third line therapy, it's usually either a bezafibrate or a fenofibrate, and then obeticholic acid in whichever order.
Correct.
Okay, perfect. Okay, thank you very much. That's helpful. We have another question. Now, this is interesting. So I'm on 250 milligrams of urso because I'm intolerant. On elafibranor second line therapy, and numbers are good, ultrascan good, consultant suggesting that I drop the 250 milligrams of urso and just stick with ELA. Now, we'll know that this is not in the trial as such, so we have no data.
No evidence, but it makes sense because you're hardly having any urso. It's barely a drop in the ocean. So and we don't know. It would be great if we had studies, and there may be a proportion of patients who just need elafibranor, seladelpar on their own without urso, and there are people who've had that without urso because of the odd patient who just can't have urso for whatever reason. So, and they've done there's not many of them in the drug trials, but they've done by and large just as well as those who with combination treatment. Now, whether you can extrapolate that to the larger pool of our patients is we don't really know, but if someone was only taking a minute dose of urso, I wouldn't make a judgment if they dropped that urso to see if they can manage without it.
Okay, perfect. Thank you. Here's a question. Magnesium and CoQ10 versus melatonin. So if you read the leaflet for melatonin, it says do not take if you have liver, kidney, or autoimmune diseases, as not tested on these conditions. So what benefit do we have of magnesium, coenzyme Q10, and melatonin, please? A nice, easy one.
Zero evidence field. That's what
Oh,
I'm going to
wow.
say. There's no evidence for any of them, and no studies done on any of them, and we don't know if any of them really truly interact with our drugs. Probably none of them interact with our drugs. Can't imagine magnesium would. I can't imagine. What was the first one?
Coenzyme Q10 and melatonin.
Yeah, I can't imagine melatonin would interact. Certainly, if someone didn't have severe liver disease, I can't imagine you couldn't take any of those.
Okay.
But
Perfect.
no one's done any of those studies because there's really no demand to do those studies. It would be the focus of studies is to look at the treatment for PBC, not to look at PBC and every supplement available that may or may not interact with these drugs.
Okay, thank you. Now, curious about why so many people say that if you have PBC, you should not have turmeric or green tea. Is this true? And what information do we have in terms of foods that are supposed to be superfoods and good for the immune system? Are there any other foods that are supposed to be healthy that we should avoid?
So probably, I'm not sure where the discussion comes from turmeric and what was the second one? Green tea.
Green tea, yeah.
I'm certainly not aware of anything that suggests they're bad for PBC, and I certainly would never ask a patient or stop them having either of those. And there are no defined supplements that have shown a benefit for PBC. If that's the question, if I'm understanding that there's no specific supplements that are going to benefit your PBC. No, there's been no evidence for any supplements.
Okay,
certainly,
in terms of
the disease can affect vitamin D levels, and it's often associated with people's certain deficiencies, but you're supplementing that for medical reasons, not because you're using it as a supplement to treat the disease.
All right, perfect. Thank you. And in terms of anything that is thought to be a healthy food, is there anything that should be avoided if you have PBC?
So there's nothing that's specifically a healthy food. My advice to people in general is controlling your weight so you're not overweight would be the most beneficial thing, and appropriate dieting to achieve that would be the best thing you can do for your liver, and limit the amount of alcohol consumption if you have whatever liver disease you have, because it's a liver toxin, and a commonly used liver toxin. So that's my advice. The superfoods, none of them have so-called superfoods have shown any benefit for this illness or disease or your liver disease per se. There's evidence not for PBC, but there's evidence for other liver diseases that people who consume that caffeine is beneficial to liver function and liver viability.
Okay, perfect. Thank you. I have seronegative PBC, so that's PBC that is not AMA positive. I'm on 1,000 milligrams of urso a day. I am 52 and I am female. I had an acute DILI, which is a drug-induced liver injury, in 2021, which the consultant believes may have resulted in the PBC. Since then, I constantly get laryngitis after a bout of acid reflux, indigestion, or a post-nasal drip. They have a very dry mouth, which the doctor thinks is possibly Sjogren's. The question is the inflammation of the larynx or the acid reflux indigestion nasal drip all part of PBC?
It's not part of PBC. It's in that description is much more likely to be reflux related, which is common. 10% of adults in the Western world have reflux disease, and that should be looked at and treated independently of the PBC, if that's the question.
Okay, perfect. Thank you. So my question to you, off the top of your head, you may or may not know this, do we think that the percentage of people with PBC who have reflux is about 10%? Is about the same, or do we have data?
We don't have data, but I can't imagine it would be any different to the general population.
Okay.
People with PBC can get anything else like anyone else can of their age and gender, match diseases for their age. And acid reflux disease is just a very common thing.
Yeah. Okay. Question is, I'm 55, been diagnosed almost a year, never had symptoms, responded well to urso, bloods are good, fibroscan's good. Am I likely to experience any symptoms such as itch and or fatigue? Because I don't feel any different now than what I've always done.
So Robert's heard me speak on this before, and he's not going to ask me a left field question. So yeah, look, first of all, it's unlikely, really, you've probably got very mild disease that's very responsive. In saying that, the symptoms don't always parallel biochemistry. So you can have abnormal biochemistry, very abnormal biochemistry, and have no symptoms, and the vice versa. You can have normal biochemistry and still out of the blue get symptoms. I think it's less common and less likely in that specific scenario you've painted, but you could still get symptoms. And Robert's heard me give talks on this before, and might ask me something totally unrelated about autoimmune limits.
So I'm good. I'm good. I'm behaving today. Right. Can people with PBC use collagen supplements?
Don't see why not. I can't imagine why not. I don't think anyone's looked at that. So I'd go into it with an open mind, but rationally, I can't see why not.
Okay, perfect. Oh, here's a great question. So,
That's trouble.
For somebody whose biopsy clearly shows PBC, I love this question. Right. For someone whose biopsy clearly shows PBC, how are those findings different from alcohol-related liver damage?
So alcohol-related liver damage and PBC findings under the microscope, when the pathologist looks at it, they're very, very different findings. So with PBC, you get destruction of the small branches of the bile duct, which are bile ductules, these little microducts. They get destroyed. They get inflamed and destroyed, and they have inflammatory cells around them. They have inflammatory cells in what we call the portal tract, and destruction of the bile canaliculi or bile ductules, which are much smaller than you can see on Robert's model. And then on top of it, you not only get that, you can often get granulomas formed, which are collections of inflammatory cells that take on certain pathological characteristics that the pathologist is going to recognize. Alcoholic liver disease causes fat in the liver. The fat starts around what we call the central areas of the liver, the central vein, not the portal tracts like PBC. And you get specific patterns of inflammation. You get inflammatory processes that the pathologist recognizes, like ballooning, ballooning cells, and you get things called Mallory bodies. They don't remotely resemble each other. It's like saying, what's the difference between a cat and a dog?
Okay,
So
that's a great way of putting it. So
yeah,
I'm going to completely overstep my mark, but I'm just going to share this. So I love this liver, and I can't remember what everything is, and I'm sure Martin will be able to tell you what the different damages are. But what I'm going to point to you is this bit and this bit. So the green is what
is the
we
drainage
call,
system, the bile duct, and then the gallbladder.
yep,
And the gallbladder where his finger is now. And those little microscopic branches are the green bits illustrated, if you can see them in Robert's diagram. They're little micro branches. It's sort of like you get like little creeks going to streams, going to rivers, going to major rivers into the ocean. And that's a bit like this.
wonderful. Thank you. And I just want to show you this bit. So this has got little bits of 3 different tubes. And the way I try and describe that is an electrical cable. And if you were to cut the electrical cable and open it up, you see the sheaths that carry the copper wire. And you've got the 3 sheaths that are together, and you've got a vein, an artery, and your bile duct. And those go in the 3 tubes, and they're kind of like that. And they're throughout your entire liver. Is that a fair summary, Martin? Does that help?
Yep, that does help, yeah.
So thank you. I'm delighted that somebody's asked that, and that's out there now. So thank you very much. Question now, right? Okay, this comes up. So I'm going to talk to you if you're asking this question, and I'm now talking as a patient advocate, and Martin as a clinician will have another view as well, which I'm going to ask you in a second. So we are asked many times what caused my PBC. And I think it's very rarely, if ever, we know what the cause is. And this tends to be a question that's asked by the newer or more recently diagnosed patients because it's important. You're coming to terms with shock and all of those kind of things. But what I would say to you is that the why is not the important part. It's the what happens next is the important part.
Fully agree with that. Fully agree.
It's the do you get on the right treatment is the important part. Are you seeing a good clinician who's going to support you clinically in your journey? Are you in touch with a patient support organization that can help you deal with these type of questions? So all of those bits are the important part. But with that said, I'm still going to ask you the question, Martin. Could a flare-up of psoriasis and sepsis after a 6-week hospital stay, could that have caused my PBC?
I don't believe it's the cause of your PBC, no. And we have no evidence that causes PBC. PBC, it's unlikely there's a specific acute event. We don't really know, though, to be honest. Like someone asked, I had a dilly and that caused my PBC. We don't really know that. It's someone surmising that. And it may have been the final straw, the precipitant that finally did that. And some infection may be the final straw that it declares itself the PBC. But we don't really know. What we understand is that someone's has genomes, so it's part of the genetic material, a combination of immune genomes that says you're likely to attack the immune system in a particular manner and become overactive. So people are saying they want immune stimulants. Really, this is an overactive immune system that's it's disturbed in an overactive way, and it's very narrow in its spectrum because it's only causing this disease. But something has to trigger that and wake it up or activate it. And there's a whole hypothesis on triggers like previous smoking, urinary tract infections. There's a lot of a concern that may be a factor. Certain perfumes and cosmetics may be a factor. We don't really know, though. That's the truth. And we don't know what circumstances you might need a further trigger. So was the infection the final straw? We don't really know that, Robert. And I fully agree with you. It doesn't really matter. You can't change that. People ask, why all the time, but you can't. Why doesn't really achieve anything, whether we know or don't know, because it doesn't change what we need to do and how we manage the disease. And people have to come to terms with that because they need to move forward. And they need to move forward in the best way they can deal with the disease. Why doesn't really never really helps us deal with the disease because you can't change it. It's happened.
Yeah, no, absolutely.
So
It's a great point.
I don't think as a clinician we get asked that question just as much as I guess patient advocates do. And it turns out I have a same answer as you.
Okay, well, so and it's good, and I think it's important at this moment, just while we're on this topic, because you're absolutely right. The why doesn't help, but it's a perfectly natural question. It's a really natural part of it.
I think you have to come to terms with the fact you have the disease, because solving the why, even if we gave you an answer, doesn't fix the disease. This is a chronic illness until we have a cure for it, and that should be our priority to deal with getting that person healthier and better and preventing serious liver disease down the road is the best way to deal with this. And obviously to deal with symptoms if people are symptomatic, in the best way we can with whatever we have today.
Perfect. Thank you. So again, if you're watching
and I'll add to this, we would have never imagined we have these second-line drug. Like 10 years ago, I would never, I couldn't have imagined in my wildest dreams we'd have these drugs emerging that we have today, and some further drugs potentially in the pipeline. So it's an improved, for people who don't know what it's like not to have these drugs because they're newly diagnosed, this is an improved world, and it should make your life better, and it should make the doctor who's your specialist or your consultant's life better as well, because we have more choices.
No, absolutely. And it's fair point. So it's February 2026 that we're recording this broadcast. And the PBC Foundation has been going for 30 years now. This is our 30th year. And when the foundation first started, the standard of care for PBC was liver transplant. And there was this newfangled thing that might or might not work. We're not entirely sure, but it's called ursodeoxycholic acid. And then we're having conversations about second-line therapies. And now, and I think this is the first Q&A that I've been part of, where we've formally talked about third-line therapies. So it's an incredible transformation in
a very short space of time.
Yeah, absolutely.
For a rare disease, it's very short space of time. When I first met Robert, and it's not that long ago, you remember that talk I gave in Japan, Robert? There was no mention of second-line therapies were still not yet in clinical trial. How many years ago was that when I joined the foundation? 8 or 9 years ago,
So, no, absolutely. Absolutely. So
they weren't in clinic. Seladelpa and elafibranor and even obeticholic acid, they were sort of, people were a bit thinking that obeticholic acid might be a good drug for fatty liver disease, but the company were thinking about it for PBC. And they were just talking about it. They weren't running studies yet. So it's transformed rapidly, just for those that are new in this area. You're more fortunate, and your clinicians like me are fortunate. I see ourselves as fortunate as well, because we have a better way we can treat more people with better outcomes.
Indeed, right.
Not perfect. We certainly can't treat everyone, and we're not perfect because we wouldn't still be doing this. But we certainly have made big inroads, substantial inroads, if I could say that.
No, absolutely, 100%. So thank you. I appreciate it. Okay, we have a general question. So I might break it down, but we'll ask you the general question. Let's see how we go. Should more scans become mandatory in the surveillance of PBC?
I'm not sure what you mean, what type of scans. I think ultrasounds and CT scans, I think that's what you're probably referring to. It doesn't help us that much, really. I hardly ever order them. It doesn't really. There needs to be a clinical need, and certainly in Australia, and I'm speaking from an Australian experience, we can get our imaging in a reasonable time frame done to a high standard, but we don't order them that often and I could order them every week if I wanted to. So there's no restrictions on me, and I don't order them that often because it's not that helpful to us in the management of most of our patients. There are exceptions to that.
Okay, perfect. So if I may, let's break this down then. So let's try and turn this from a big general question. So let's be slightly more specific. So if I have PBC, how often would I, for example, expect to have a FibroScan?
It's still evolving that, but I
Yep.
think, and it depends how bad your initial FibroScan was. If you
Mhm.
have a normal or close to normal liver stiffness score, I would say every 2 to 3 years. And we're in a situation where we have FibroScan machines. There's lots of countries where there's and I don't know who's online, where there's low access to FibroScans, and
Yep.
I don't think they should feel hugely disadvantaged because we've managed our patients quite well before we had FibroScan. So I don't want people who can't access a FibroScan to feel hugely disadvantaged. There are somewhat disadvantaged, but not hugely. And ideally, probably every 2 to 3 years, is reasonable.
Okay,
And that's
perfect.
probably
Thank
what
you.
I would do. If someone had very advanced liver disease, you might want to do it, more a high liver stiffness score, you might want to repeat that in 12 months' time.
Okay, perfect. So before I move on, I just want to say something. So FibroScan is a specific brand, but we talk about liver stiffness measurements. And
Can I excuse myself
perfect.
for 1 minute?
Yep, of course.
PBC related.
So while Martin's doing that, so we talk about elastography. So we talk about the elasticity of the liver. And some of you might be of the same generation as I am, so you'll be old enough to remember the make Hoover, who made vacuum cleaners. And in the UK, we talk about doing the hoovering. So I'm going to hoover that room. And we might use a Dyson, we might use a Shark, we might use a Henry, but we're going to hoover it because that brand just became the verb. And FibroScan is very much like that. So for all there are different brands that make very similar technology, we've somehow turned FibroScan into the verb for all of that activity. So I'm hoping that helps.
Sorry, Robert. Just
That's okay.
I've been trying to get an update on seladelpar availability in Australia. So that was a phone call from someone high up in the company that I've been trying to get hold of to update me. What a coincidence while I'm having this conversation.
So bearing in mind that this will go out in the public arena, is there anything you can tell us about seladelpar availability right now?
I can't say everything. I can say seladelpar's had Therapeutics Goods Authority approval, so the equivalent of EMA or FDA, recently. And it's still waiting for the funding through the Pharmaceutical Benefit Services, and it's still waiting for approval.
Okay.
In the meanwhile, I can say this, they are trying to set up, because they can now, the drug is legal in Australia, set up to specialists who are expert at this, some special access program if patients fulfill a certain profile. They haven't set that up yet. There's a lot of commercial and compliance issues they have to go through. So I can't give anyone seladelpar right now. But
okay,
I think
I'm
encouraged that in the not too distant future it will be available.
All right, that's good. All right, fingers crossed. And as it stands currently in Australia, can you give elafibranor?
Yes, I can.
And can you
if
give
they
a
meet
benchmark?
criteria? They have to meet a whole bunch of criteria, and then elafibranor gets funded, and you can get approval for it, and you hand the prescription in with that government code and approval. It's through a phone mechanism, and you have to fulfill a bunch of criteria, and then the government, you get an authority code, which you put on the prescription, and they can go to any community pharmacy, any commercial pharmacy, and they'll order the drug in on that basis because they'll get paid for that drug. And they'll say, I've never heard of this drug because they haven't. And they'll say, quite the first few patients I prescribed, the pharmacy said, I've never heard of this drug. this is new, which it is.
Okay, perfect. Okay, so thank you. So, my last question, obeticholic acid is available in Australia as well.
It is in Australia. It is available in Australia.
Okay.
And it's got a black box warning, so we can't give it in people with liver failure, with significant cirrhosis. So there are restrictions on the drug, and because of some of the controversy around the drug, the company has to put a black box warning on the drug, and the company were obliged to send a letter informing all doctors. So they basically sent it to all gastroenterologists as best as they could, a mailing list to say that these are the restrictions on the drug, but we have easy access. It's the same process. We phone and get approval, and we can get that approval, and there's no problems getting approved.
Perfect. Thank you. Okay. So we were talking about scans, and we just talked about FibroScan. So my next question is,
and
if you have
FibroScan
PBC,
always, as you said, is a commercial brand. It's the original brand. It's got a registered trademark FibroScan. We have two of those machines, in fact, three of those machines in our hospital, so we're just fortunate. But there's a lot of Me Too companies. So all the companies that make ultrasounds, that when you go for any ultrasounds, they have elastography. Shear wave elastography is the technology built into their ultrasounds now. So if the doctor or the radiographer doing the ultrasound is familiar with it, they can get an elastography done equivalent to FibroScan.
Okay, perfect. Thank you.
And our radiologists, if we send someone for a liver ultrasound in our hospital, they automatically do an elastography as well. We've made a deal with them to do that.
Fantastic. Brilliant. Okay, so here's my next question. When or how often would you use ultrasound in PBC?
Very rarely. Initially, you might use it as part of a workup of liver disease, and some patients you may never need to do it again. You would do it if liver tests surprisingly became very abnormal and you'd think something else is going on. You would do it in patients who have cirrhosis of the liver. It's probably 6 monthly to screen them for early liver cancer. And you might do it if they got some sort of other pain or something unrelated for another indication. For the average person I get to see, they rarely have another ultrasound. It's not a limiting factor, and it can sometimes be overstated. I see there's a question on. Sorry?
Yep, I will come to that, but bear with me. And then the other thing I want to ask you is about MRI, so magnetic resonance imaging. Is there ever a need to use that?
You very rarely need that as well. So you do an MRI, and this is current technology changes all the time. You do an MRI with a type of MRI called MRCP, where they look at the bile duct and pancreatic duct. And there's a related condition called primary sclerosing cholangitis, or PSC, for those of you who've heard of it. It's also an autoimmune condition. It mainly affects the larger ducts, but it can affect the small ducts. And it's similar, it's a cousin of PBC, so to speak, and can present in similar ways. And if you think someone may have PSC, you would often do an MRCP, which is a type of MRI, to look at the ductular system and the larger ducts in great detail. And some of those people also need to have a liver biopsy. And if there's ductular damage, you may need to do it more frequently if they have those diseases, but not for PBC. It's not a helpful test for PBC currently.
Perfect. That is helpful, and hopefully that gives a little detail about the different scans that are available for a number of liver diseases and hopefully some PBC.
I get patients, Robert, related to that. I think they're missing out by not having an MRI and not having the scan or that scan. And I have to sometimes spend a long time explaining to them that I need to have it done.
Yeah.
And there's no benefit. They're not missing out, So they even come to see me for a second opinion. My consultant I'm angry because they didn't do the scan, and they don't need to have the scan done.
So, no, perfect. And that's why I asked the question. I thought it was really important to go into that level of detail. So again, we can reassure patients that actually sometimes these scans and these tests are not what they need. Okay, we've got a question in the room. So,
Very good
FibroScan
question.
of 5, taking a diagnosis 4.5 years ago. FibroScan's now 10. Alk Phos currently 192, and bilirubin of 10. So again, we know that, we're not at optimal levels of blood tests and all of those kind of things. So again, we cannot talk about individual cases, but if we have a patient who the FibroScan is going up in terms of the kilopascals, they're on our soap, but their ALP is not normalizing. What would be the next steps? What are the questions they can ask their clinician?
So if the FibroScan is a good quality FibroScan, and I'm not referring to the specific person who's put the question up, because again, I don't know you and what you and your consultant have discussed. But if you've got a rising FibroScan and you're not very overweight, that is probably a real result and needs to be taken seriously, and it is a sign of it's likely to be a sign of progression. If you're on the appropriate dose of urso and your ALP is creeping up in that context, your doctor would almost certainly want to initiate a second-line agent. So if you're based in Australia, you're either going to get elafibranor or obeticholic acid, but you will need a second agent. And if you, in some countries that don't have these drugs, I would give that person a fibrate agent. So it depends if you have bezafibrate or fenofibrate, and there are other fibrates in South America as well. So I would give that patient, if I didn't have the newer second lines available, I would definitely put them onto fenofibrate with the urso and see if you get a response over 3 to 6 months. And by response, downward, a declining ALP level, really in a reasonable period of time. The FibroScan changes won't change in 6 months, but it is something one has to take seriously if there's been that jump in a FibroScan reading and an ALP that's suboptimal, and that does need to be discussed with your consultant.
Perfect. Now, this question has got nothing to do with this case. It's purely hypothetical. But are you aware of what second-line therapies are available in New Zealand?
None of the new drugs are available in New Zealand.
So no,
as far as I'm aware, and the level of knowledge of these drugs amongst my New Zealand colleagues, by and large, that when we were at EASL last year and you bump into them, oh, what are you doing? I'm going to talk about elafibranor. I'm having a meeting about seladelpar, and they look at me like I'm come from another planet, it's just New Zealand gets these drugs a lot later usually, but they will have a fibrate agent there, and that would be a good option, because until recently that was my good option. So they probably do have fenofibrate in New Zealand, I'm imagining, or similar, and that's a good option in that scenario. Definitely a good option, and old-fashioned option, but a good option.
Okay, no, that's helpful, and that's good to know, because I guess that's our next destination for seeing if we can make a campaign. So good to know. Thank you very much. All right, here's a question. So 16 to 8 intermittent fasting. Again, there's a lot of conflicting information out there. Some say that 16 hours is too long. Some say that fasting doesn't work with PBC, etc., etc., etc. So, any thoughts on intermittent fasting with PBC is my first part of the question.
I'm going to answer that in two ways. First of all, if some people, I've had patients who've used intermittent fasting mostly around fatty liver disease because they need to lose weight, and they've struggled and they've used that, and some people have used it successfully. There's a new paper out that only came out this week that says it's probably doesn't benefit most people, and some individuals do benefit from it. I can't see it being a negative thing for PBC. So all that fasting does is create low levels of ketosis, which is a metabolic state that sometimes diabetics get. And diabetics get it very badly. It's overdone, so it can be harmful. But ketosis helps some people lose weight, and they generally eating less if you're fasting for longer, so you lose weight as well. And if that's going to help you lose weight, well and good. I can't imagine, but no one's done that study, so I have to put a caveat on it. But I can't imagine I can't see a way it would be bad for PBC.
All right, perfect. Thank you. That is helpful.
I think that's what the person's asking.
Yes, indeed. Okay, so, right. So we have a question, and I'm going to take a slight left turn with the question. So, on a personal level, as a patient advocate, one of the things that boils my blood is when a patient is told they have deranged liver function. So, can we talk about two phrases, please, Martin? Can we talk about deranged liver function, and can we talk about abnormal liver tests?
So I think it's, I think we can overstate that. So people use different terminology. Abnormal liver test is probably the more correct technology, but if it's deranged, it sort of means the same thing. Or, the liver tests are high, or elevated, doctors are going to use different terminology. And it's their whole textbooks and chapters in textbooks that are written on abnormal liver tests or elevated liver tests, because there's a lot of people out there where we never work out why their liver tests are abnormal. And as long as it's not threatening to them, as long as it's not causing progressive or fibrotic liver disease, it makes no difference to them other than causing worry, because they're looking at numbers that 20 or 30 years ago, no one got lots of numbers and blood tests they couldn't look at. So they blissfully went out about their business being unaware they have these abnormal liver tests. So I see some people for 20, 30 years with elevated or disturbed liver tests and abnormal liver tests, and we've not found a cause. If the doctor's worried the liver tests are too high, or there's a pattern, we look at patterns of abnormal liver tests. So they're, depending on which country and which laboratory is done, there are 6 or 7 liver tests. Liver tests are quite rudimentary, and this has been what's available since maybe way before I started medical school. You're talking 60, 70 years. The same liver tests were done. They're perhaps more sophisticated today. We've worked out that the gender differences, that women tend to have lower liver tests than men. We've worked out that kids have lower liver tests, except in ALP, than adults. So we've learned liver experts learn to understand these small nuances, but the average doctor doesn't need to be aware of that, except a high ALP is normal in children. And we look at patterns. So we look at broadly 2 main patterns. You can have cholestasis, where you have a high ALP, maybe a high GGT or a high bilirubin, or varying combinations of that. And you have a hepatitic picture or hepatitis picture, where it's predominantly your ALT and your AST that are elevated, or you have both, a mixed picture. And different diseases cause different patterns. So when you see a liver expert, they think differently, depending on what pattern they see, and depending on how long someone's had that pattern for. So the timeline of that pattern as well, and change over time. So it can start as one and evolve into another. For example, someone who has acute alcoholic hepatitis, where they get really bad acute damage from the liver, it starts as hepatitic and become cholestatic in the recovery phase. And if they're not drinking and they're not too sick, they get better eventually. So they go through different phases. That's just a very striking example of a case that was presented at our hospital grand rounds today. So a very fresh example. So we have these abnormal patterns. So it's the duration, the durability, the pattern, cholestatic, hepatic, or both. And then we have synthetic function, which is really the albumin, which is a protein the liver makes. So if that gets low, that's a concern if it's too low. and we have globulins that are often put together with liver function tests, and high globulin levels when it in the context of abnormal liver tests make us think of autoimmune liver diseases, for example. If the bilirubin's raised, if it's it may be part of us, it may reflect liver function, but it can also reflect cholestasis. So it depends on the combinations of liver tests are very important, and sort of have to become an expert of this like us. You learn this over time, and you learn all the, the people who train under us learn all those nuances. They see things quite narrow to start off with, but then they learn all these little nuances and how to pick them and how to make judgments. Is that what you want me to talk about?
It wasn't the question I asked, but I'm delighted that you answered that, because I think that was a really, really nice breakdown of some of the tests and different types of tests. And I think that's really helpful. So I guess what I was asking was, so for me as a patient advocate, and if you're a clinician watching this, I'm going to ask you really, really nicely to consider when you use the term deranged liver function and when you use the term abnormal.
But some people do. I'm not, to be honest, I'm not that fussed. It depends on your culture and where you've come from and what the background is.
Yeah.
We just say you've got abnormal liver tests or elevated liver tests.
Yeah. Perfect.
And
no, that's
we don't
helpful.
even use the term elevated, but sometimes the albumin's low, so it's not elevated, and that's an abnormal liver test. So it depends on the context as well. I don't get that upset. I can see why it would upset people. I don't get that upset about it. I personally don't use that term, but I guess I understand it from doctor to doctor what they mean.
No, 100%. I just know that, again, when we're offering support on our helpline, the conversations we have with somebody saying, I've got abnormal liver test, what does this mean? And then somebody comes in and goes, look, I've got deranged liver function, I'm really scared. So, what's matter?
Yeah, I get that. I do. It's a bit of a harsher term, but I guess I'm hearing it more from doctor to doctor, and I would know what they mean.
Yeah. Indeed. So, question. I have just found out that I have compensated cirrhosis and PBC. Is it possible that the URSO can still keep things stable? And is it possible that my liver damage can regress?
So it's highly unlikely your liver damage can regress if it's reached cirrhosis. We don't have drugs that treat cirrhosis yet. We will probably have anti-fibrotic drugs in the not too distant future that can reverse fibrosis, which is what we'd have to do. Once cirrhosis has crept in, so target for me, if I saw someone who's already cirrhotic and they're not decompensated, so they're well compensated, is to keep them that way forever and ever and ever and a day. Otherwise, they're going to need to have a liver transplant, and we want to do our best to keep them well and healthy. So most people can have quite a normal life with compensated cirrhosis, well compensated cirrhosis. It doesn't limit them too much. It can, but a lot of people will have surprisingly good day-to-day function, if for want of a better term. URSO may work, but really the studies which came from France that got URSO on through all the various regulatory authorities in its day, and I can remember the first day it was put onto. I can remember speaking to the person responsible day one when it became available in Australia as a younger specialist, but URSO may work, and I've had the odd patient where URSO, it works. But we know that URSO ideally should be introduced early in the disease. The earlier you introduce this, so I would say before you have fibrosis, even early fibrosis, you're much more likely to get more people many more people will benefit from it at that level of disease. Once you have compensated cirrhosis, a small number of people would benefit. It's not to say you get zero benefit, but you're looking for a more comprehensive benefit, like a normal ALP. You may not get there. You may, it's not impossible, but it may very well not happen if I'm speaking as a real doctor and really honestly. And it's fortunate that whoever this person is, they're going to be in the era of second-line therapies, because you may benefit from a second-line therapy. So you'd probably want to give it 6 to 12 months. I'd assume your specialist would want to keep a close eye on you because you're already cirrhotic for lots of reasons. And so I'm quite sure that they would start URSO and they would have a low threshold to add a second-line agent. That's how I would think, very broadly. And again, I put that caveat that I don't really know your illness and I don't really have everything in front of me that would help me give you a personal opinion. But that's in general terms. You're in a more aggressive situation, and so your consultants are going to have to work with you to give you the best outcome. They're going to have to work a bit harder and think more, take your, and I'm sure they'll take your disease much more seriously.
Okay, perfect. That's helpful. Only thing I would add, so obviously, we've been going 30 years, and that in the olden days, so this is before my time. This is when Martin was young. No, back in the day, it was more common that people with PBC did have cirrhosis when they were diagnosed, and we've
much more common, much more
Yeah.
common, and many more people would die at a younger age than they do today. It was not uncommon to, when I have these memories of training as a specialist and doing ward rounds and, having these older ladies, which really were, 70-ish, dying of liver disease and coming in and out of hospital and managing their end-stage liver disease because that's all we could do. And that, and people often misdiagnosing. They had this burden, that psychological burden, because they said, oh, there must be a closet alcoholic, or there must be this, often in the early day, before they got a formal diagnosis. So they lived with all that guilt as well when they knew they maybe never had a drink or never did anything bad, never, so it was quite awful. And they're mostly women who are just literally going to die. There wasn't even much palliative care around in those days to palliate people.
Yeah. So, yeah, absolutely. But I guess what I want to say, in the advent of URSO, that changed things. But I've known people,
Massively.
and I'd say multiple people who were at the point of decompensated cirrhosis at the time of diagnosis and who responded to URSO. And again, going back to
those people, there's not zero chance to respond. It's just smaller than someone who's got zero fibrosis. I had someone I just saw the other day who really surprised me and has had a profound response to URSO, who's much like that scenario you've just described, and doesn't even need a second line agent, doesn't even need to think about it. It's had such a great response.
Fantastic.
So it does happen.
And this is the key. It's not what brought you here, it's what happens next. And so thank you. Right, one last question for you, if I may. So, and this is, so the person who's asking this is female and 49. So they've said that, there might be a perimenopausal aspect to this, but they have fatigue. They take vitamin C, D, iron, and B12. Are there any other supplements that they could take for their fatigue?
Well, look, to be honest, probably not. I would be very careful about taking iron and B12 unless you're deficient. Too much iron actually accentuates fatigue and is bad for liver disease. It causes more oxidative stress in your liver. So I would countenance you to not take iron if your iron levels are adequate. If they're depleted, that's different. And the same for B12. We're starting to learn now that too much B12 may not be so good. We never used to worry about it so much, but there are some suggestions that there's toxicity from that. There's certainly toxicity from too much vitamin C. That's well known. And so I would count, and I don't think vitamin C does anything for fatigue. It's not a fatigue supplement in any circumstance. So there's no known, there's really, I wish I was going to give you, other than treating your disease as best as you can and using whatever aids you can, be it, trying to get adequate sleep, trying to get adequate exercise where you can, and trying to get the right support that you can. But fatigue is very hard, and it's hard to judge it because there's often other factors that contribute to fatigue. So often fatigue is not just disease related, it can just be disease related, and I don't want to be dismissive of that, but sometimes there are other factors. So it may be that perimenopause can contribute to it in some women. There may be other personal factors that contribute to it, and other psychological factors, but these supplements don't really make a huge difference unless you're deficient.
Okay, perfect. Thank you. And again, on behalf of the foundation, I can say to you there is a fatigue clinical trial on the go. So that might be available to where you are. And the other thing is, if you are experiencing fatigue, whether you've asked the question or whether you haven't, you're always welcome to come to us, reach out to the helpline, have a conversation with us, because there may be parts of your life where we can help, and it can help address the fatigue. And there's good data now, particularly coming out of Canada, that says that your lifestyle management and the things that you do to help yourself in the softer areas, so things like mindfulness and meaningful movement and all of those kind of things, can have a huge impact positively on your fatigue. So do feel free to reach out to us.
Yeah, I'll be supportive of that for sure. Yeah.
Okay, perfect. That's
sure.
Okay. I've not done one of these in ages. It was really, really nice to see you today. So thank you so much.
Yeah, I haven't. Well, I did one. The last one I did would be late last year, maybe November or early December.
Okay, and perfect. Are we seeing you at the summit?
So,
are we seeing you at the summit?
Robert. They just sent me my airline ticket, which you guys have to approve.
Oh, right. I will. Right. I'll get on that. I'll look for the email. So we will get that approved. And so thank you.
Good.
Wonderful.
So
right. If you've been asking
very good. I'm going to see you at the summit. Yes. I'm excited, actually.
Wonderful.
I always come back very, very motivated after speaking to everyone there. I feel, well, this is a good area to be in. There's a lot of good people. There's a lot of people right across the spectrum, doctors, pharmaceutical companies, and patient advocates. And just in general, there's a lot of people you think, wow, there's a lot of nice people who work in this field who are very motivating as well, watching what everyone does and trying to do, including we sometimes don't thank all the people who work behind the scenes in the foundation, and they really do fantastic work and always very appreciative of whatever the doctors do. And I enjoy this. It's extra work for me, but I enjoy these interactions, as Robert knows, and it's hard to say no to the foundation, to Joe and Robert.
Thank you.
And
no, I appreciate that.
Mo, Joe, Robert, everyone. I just say yes.
No, it's an immense team. So what I would say to you is, if you're watching this, look out for news about the summit, because we do come together. It's clinicians, it's patients, it's patient advocates. We have pharmacists, ethicists, nurses, industry all coming together.
People who just work in putting everyone together. Sometimes is whatever you call those people. They putting everyone together strategically. They play a role as well, Oh,
it's huge. It's huge. And the other thing, if you're watching this, if you're interested, we have a couple of surveys on the app. So if you're using the app and you want to have a look at the surveys, please do go and do that. One's on fatigue, one's on itch. And even if you don't have them, it's really, really important that we get your data so that we can use that to help you get better treatments. Martin, what were you going to say?
Yeah, and I was going to say one thing for the Australian audience. Bunch of experts have got together and drawn up. We're not calling it the guidelines because we weren't elected by any committee, but we've called it a consensus, a consensus around treatment of PBC in the Australian situation. So it's sort of like a guideline, but we can't call it that because we weren't elected by anybody, but a bunch of experts have got together and drawn up guidelines that's been submitted for publication. And the idea is that a broad number of specialists have access to that, who don't work at as much as without being patronizing as much as I do or some of my colleagues do in the autoimmune PBC space. So but they might treat the odd patient. They're going to have a series of consensus statements that they can, and how to do it, and what's the expectations around standard of care. Robert will be pleased with this. It's the first time I've been involved with anything that we've included a consumer patient advocate as an author, and hasn't looked over the technical stuff, because she said quite clearly, I'm not going to judge that. But she has given her perspective about things she wanted included, and that we should think about when we write the guidelines from a patient's perspective. She decided not to come to our regular fortnightly meetings because they were mostly around, publication stuff, criteria that she wouldn't have knowledge about. But this is a very, very smart person who went through a journey, has cirrhosis of the liver herself from PBC, but has done exceptionally well and is a very strong voice, because she's very outspoken and a very smart person. And so I'd recommended her, and the committee, the group of experts, were really liked that idea. So there you go. The doctors really liked the idea there'd be a consumer participant.
So congratulations and thank you. I was going to ask that question, and the fact that you've incorporated a patient into the writing committee puts you above ASLD and puts you above ISO. So
that's good to know. So we're not representing the Gastro Society. We sort of went to them, can we do this? And it was going to take too long, and we felt a need for it. And went to a journal and said, if we get a professional writer, because we're all busy, can we get this done? The professional writer met with us every 2 weeks, and how to do it. We'll do a lot of work, a lot of writing, and get, references and collating and discussing things. But it's come out with a very good consensus, and a number of colleagues from around Australia that have contributed. So, and including the consumer, which I think, so we've learned those things from my interactions, how important that voice is. And as soon as it was suggested, everyone said, yep, that's actually a good idea. Why not think of it? So it shows you that the medical profession at our level certainly is very open to that, Robert.
Wonderful. I am absolutely delighted to hear that.
I'm sure you get a lot of pleasure out of just hearing that statement. Yeah, not a single person everyone said, yeah, great idea.
Awesome. Thank you so much. Amazing. Thank you.
So you will see those when they get accepted for publication, Robert, obviously. I know we'll send them to you guys. And we try to, because I've been working with the international committees and guidelines that aren't yet published, my knowledge from there, I've tried to say, you can't say anything that's going to be very conflicting unless you have good evidence. So I've tried to keep some people who have slightly divergent views. I said, if these come out in the next year, you don't want to have a very divergent view. You want an Australian perspective, but you want to be in line with international perspective, because that's what we're trying to achieve. Like everywhere aspires to excellence, and if we set the bar at a certain level, every country should aspire to that. And you've been passionate about that, Robert, as have a lot of your advocates.
Amazing. Thank you so much.
Nationally.
All right. Wonderful. Okay, if you watched it, thank you very much. Appreciate it. Bye for now.